Hello, this is the Duke Tobacco Treatment Education Program. This is part 2, where we discuss pathology related to tobacco use. I'm James Davis. I'm the medical director for the Duke Center for Smoking Cessation and the director for the Duke Smoking Cessation Program. And this program is supported by an independent education grant from Pfizer. So I want to start off just talking about mortality in general from smoking and globally. First of all, globally, 1 in 5 adults smoke, or 20%. And the statistic now on the number of people who die from smoking has really become profound. We're right at around 50% of all people who smoke will actually die from an illness caused by their smoking. And that is data that has come through a covariate analysis so that we have teased out those other potential causes of death, obesity and genetics and all of these other things, to actually identify a rate at which people die from smoking. So if I'm in a room with 10 people who are smoking, 5 of those will most likely die from an illness related to their smoking that was caused by their smoking. Globally, we are still at around 8 million deaths per year, so a very large number. And in the last decade, we've essentially lost about 100 million people globally, which is really, really profound. We have, in the United States, we have data that differentiates different causes of death, smoking-related death, and roughly, I should say, this data is available all over, but here's the U.S. data. In the United States, we have about 500,000 people dying per year, and it looks like about a third is from heart disease, and about shy of a third is from lung cancer. Then we have COPD, other cancers and other diagnoses after that. So the really big players here in terms of smoking-related death are actually lung cancer and heart disease, with COPD kind of coming up third. The way that I think about the illness related to smoking, and this is really the way that I talk to patients and the way that I would encourage you to talk to your patients, is that smoke comes into the body and affects the lungs. And I think patients know this. This is something that's intuitive. However, beyond that is not that intuitive. Once it's in the lungs, it then moves into the vascular system, and it moves into the blood. The toxins from the smoke do. And it's worth saying here that the surface area of alveolar transport between lung space, air space, and blood is roughly the size of a tennis court in an adult human. So I'll say it again, the area, the surface area of the lung that allows for transport of smoking toxins is about the area of a tennis court, which is incredibly efficient in terms of its capacity to move toxins from smoke into the bloodstream. Once toxins are in the bloodstream, what we get is coronary disease, which is the buildup of plaque in response to those toxins. The buildup of plaque also, of course, in the heart, but also in other vessels of the body, the brain as well. And then we also see on the venous side, we see clotting factors activated, which leads to an increased incidence of deep vein thrombosis and pulmonary embolism. So a number of changes that are purely vascular as those toxins enter the bloodstream. Then the next thing that happens is those toxins move out of the blood and into cells in the body. And here we see inflammatory changes in response to those toxins that lead to diabetes, that lead to bone loss, cataract formation, erectile dysfunction, a whole litany of different problems, and we'll be looking at some of those. The final place those toxins affect is actually inside the cell, in the nuclei of the cell, which is the DNA, and there it leads to poor transcription, to transcription mistakes and translational mistakes when the DNA is dividing, and that leads to cancer. So very kind of, and this is one of the ways that I talk to patients, is I'll leave out the sciencey language, but just simply say, when you breathe the smoke in, it comes into your lungs and it affects your lungs. Then the toxins go into the blood and they affect the vessels all over the body, and then they go into the cells of the body and every organ of the body, and they change, there's inflammatory changes, and then it affects the DNA. And I think you can say that pretty simply to give a sense of scope of how smoking actually affects the body. Now let's take a dive into COPD. This is so common in smoking, and I feel like it's important to have a more nuanced understanding of COPD because it's so common. So first of all, the diagnosis of COPD, and many of you are in medicine, and this is going to be old information, but I think it's helpful just to kind of repeat it, even if you've heard it before. Emphysema has two components, and two components are required for the diagnosis. COPD has two components that are required for the diagnosis. One is emphysema. Emphysema, I usually talk to patients about this as scarring in the lungs, and that's because people are familiar with scars. They see a scar on their skin and they know that's going to be there for a very long time, and that is it's similar to the fibrotic changes that occur on a much smaller level in the lung. With that scarring, what you actually get is breakdown of the alveolar walls and larger alveolar spaces, and an inability of the lung to push out that air, and it's trapped air, and we call it air trapping. And what that leads to is buildup of CO, because we can't get rid of the carbon dioxide that the body's making, and lower oxygen levels over time because the oxygen exchange is not as efficient when we start losing surface area in the lung. And we're going to look at the fact that you need to lose about half of your lung function before we ever actually start seeing deficits in these areas. And we'll look at that in just a minute. The other component is really an inflammatory component. So this is destruction. Emphysema is destruction of the alveoli, and chronic bronchitis is inflammation of the upper airways. And that inflammation leads to constriction of the airways, swelling of the airways, which is thickening of the actual tissues, as well as a lot of mucus production. And the way that that's diagnosed is simply as a smoker's cough. And most people who have smoked for 20 years will cough in the morning, and that's a smoker's cough, and that qualifies as as chronic bronchitis and fits the definition for COPD. So in technical terms, if you've got a person with a morning cough who then meets the criteria for emphysema, then they have COPD. Most of you have seen this, but one of the things that happens with the alveolar destruction in the lungs is that the lungs lose elasticity, and the lungs hold the chest wall in. The chest wall has an anatomic tendency to expand, and then the lungs kind of, through suction, through negative pressure, they hold the chest wall in. Well, as alveolar destruction occurs in COPD, that elasticity and that tension starts to give way, and the chest wall expands and expands. And we also see the diaphragm, which is normally arched like this and then breathes by contracting and pulling down. We see the diaphragm slowly flattening as the lungs lose elasticity and become larger. And here on an X-ray, you'll see a normal person without COPD who has this nice arched diaphragm, and that whole diaphragm can be used, that whole arch can be used to breathe by flattening that diaphragm. And then here in COPD, we see a loss of that arching. we also see much darker lungs, which has to do with air trapping in the lungs, and then just larger, big, large lungs in general. And it's pretty easy to see this on an X-ray, especially with more severe disease. So how is COPD diagnosed? I want to go over this and make it really as simple as possible because it's actually very intuitive, and I apologize to those who already know this. But there is this quality, we call it FEV1, it's the forced expiratory volume over 1 second, this quality is very anatomical with people who smoke and with emphysema, and I'll explain this as we go. So there's FEV1. So the diagnosis of COPD or emphysema is made comparing FEV1, which is the forced expiratory volume over 1 second, and comparing that to the forced vital capacity, which is the total amount of air which a person has in their lung. And so I'll just do this briefly, but FEV1, how much air can I breathe out over a second? If I take a deep breath, then I blow it out, I should be able to breathe out the majority of the air in my lungs, the total amount of air in my lungs, within a second. And I would say right there I probably breathed out 80% of the air in my lungs, of the total air in my lungs. As people develop COPD, there's air trapping, and it's an anatomic change, and it makes it difficult to blow that air out. Even if they try to blow it out quickly, the air is trapped, and there's only it just takes a certain amount of time for that air to come out. So there's an anatomic limitation to blowing out, which makes this a very precise and a very, very helpful measure because you can't cheat it. Once you are blowing out under 70% of your total air within a second, that qualifies as COPD. Now, COPD severity is actually looked at a little bit differently. It's looked at based on the percent predicted FEV1, and that is to say that that different people have different amounts of air that they should be able to blow out over a second, and that's based on age, it's based on height, it's based on gender and race, and that all predicts the amount that we should be able to, what our FEV1 should be. And if we want to determine what kind of how severe the COPD is, then we look at FEV1 compared to a predicted model of where that should be. And if you're 80% of the predicted model, that's considered mild COPD. If you're down to 50%, that's moderate. If you're around 30%, that's severe. So we start getting this gradation, and that's the GOLD criteria that we often hear. So again, FEV1 over FVC, it's a very simple concept. How much of your air can you blow out in a second? That's it. That's the core. If you can't blow much, that's COPD. It's a very, very simple idea. Lung function. Now here I want to kind of go through a couple of important concepts, and I'm mentioning these concepts because I think they're important to our patients, because we get questions on things on these things all the time, and I want to just clarify, and I think this chart is helpful. This chart shows FEV1 on one side, going up the left, and then age across the bottom. So what we have here is a chart that shows, and let's follow the blue line, that shows that there is a natural decrease in lung function as people age. And here we have somebody aging all the way out to age 85, and with that aging, if you look, there's a very important line here. This dotted line that goes right across the middle of this chart, that's when symptoms develop. And what we have with normal aging is a decrease in lung function that occurs over time, but we never get to that line where a person actually develops symptoms. So 85, 90 years old, In terms of the lung function of an 85 or 95-year-old, yes, it's lower than it was when they were 15, but they can still climb stairs, they can still do whatever if they're not being limited by other physical challenges. So lungs by itself don't limit a person in terms of natural aging. If a person smokes, essentially what happens is the rate of decline increases. And what that means is that we will commonly, with a pack-a-day smoker, we will see people hit symptoms often in their 60s. If they smoke 2 packs a day, it'll be back in their 50s. People will start getting symptoms a little earlier. But at some point, they'll develop symptoms. Now, there is a genetic susceptibility that can occur when a person is smoking that will actually lead to a much more rapid decline in pulmonary function in smokers, and that's shown by this red line. And those folks will develop symptoms in their 50s, and you'll see those in your practice. That's pretty common. Now, the important thing about this, that I think from a patient perspective, is that many patients feel that if they've smoked for 30 years or for 20 years or whatever, and they're still able to go upstairs and do all, to work, do hard work, to work around the house, to work in the yard, to do work out of the home, outside the home, that they feel like, well, smoking really hasn't hurt them. And in fact, the lungs are overbuilt by about a factor of 2 here, where you can lose half of your lung function and still function normally. But once you get down to this lower level, once you start getting down to that dotted line that goes across, then things start to change. Then you're done. You don't have any more. You don't have any more runway, and people start to develop symptoms. And this chart doesn't describe it, but in my own practice, I find this to be kind of oddly sudden, where people will develop symptoms really within a few days, and 1 week they don't have it, and the next week they do, and they say, what happened? And they feel like they got an infection or something like this. But in fact, they just finally started reaching that point after many years of smoking where they're starting to notice, okay, I can't carry my groceries up a flight of stairs. I can't walk with my grandkids or my children, up this hill. So that's an important piece. The other thing about this chart that I think is interesting and important is that there is a rather, it's this blue dotted line that you see, and there's a rather sharp increase in pulmonary function when a person quits. The dotted blue line is the line for people quitting. That increase has to do with decrease in inflammation in the body. So when a person quits smoking, very rapidly their lungs start to heal, inflammation goes away, and they're able to breathe better. And this looks like a very small increase on this chart because this is looking at it at an entirety of a lifespan. But clinically, it can be quite significant. People can go from really having very noticeable symptoms that are inhibiting their lives. They quit smoking, and within a month, they're able to do things that they have not been able to do. So this is, again, it looks small here, but in terms of patient experience, it's not. It's typically not small. It can be quite dramatic. Lung function actually continues to improve rather markedly for about 6 months, and we see that in patients. This doesn't show that subtlety because, again, we're looking at a lifespan here. Then what happens is that the person, there is some scarring that takes place, and so they don't simply return to normal smoking, but they return to the rate of decline that is normal. That's the rate of decline for a normal smoker. So kind of some interesting pieces there. One, when patients say smoking hasn't hurt me yet, in fact, that's because the body is overbuilt and it can sustain a certain amount of damage without developing symptoms. But once you're done with that, with your reserve, you're done. So kind of an important concept. This slide looks like a giant complicated mess. In fact, I think that there are some important pieces here, and let's walk through it. What this is smoking and vascular disease. And the first thing I want to bring up is this top piece, which is nicotine. Nicotine itself is not the major player in terms of the vascular impact. It does do a little bit though. It leads so when, and we're going to get into this a little bit in the next section on neurobiology. But when nicotine binds to nicotinic receptors, that it increases levels of norepinephrine, which is a stimulant that stimulates the sympathetic system, and that increases heart rate and increases blood pressure. It actually increases myocardial contractility and myocardial demand. But we're talking about a fairly small change. We're talking about an increase in heart rate of about 7 points and an increase in systolic blood pressure of about 7 points for a person who smokes a pack a day. So it's real there, and there is an increase in myocardial demand. It's real, but for most people, it's not that significant. It's not clinically significant. It's a small change, but not major. There's kind of a funny thing that we see with coronary vasoconstriction. There's actually a constrictive phase. The first thing that happens is actually dilation in the coronaries. It's a bit of dilation, better coronary blood flow, and then over time there's a bit of constriction. This is kind of again, these are also not big changes. These are very subtle changes, and it's not even clear if they're clinically meaningful or not. And people kind of argue it both ways. So that's kind of the nicotine piece. Carbon monoxide also, as we know, carbon monoxide binds to hemoglobin, and it has greater affinity for hemoglobin than oxygen, and so it'll kick off oxygen. And so when you have a bunch of carbon monoxide in your body, then that will decrease oxygenation because you've got carboxyhemoglobin running around in your bloodstream instead of oxygenated hemoglobin. And that being said, carbon monoxide also is not a major player in terms of decreased oxygenation, in terms of kind of the clinical manifestations of smoking. It's there, it's measurable, but it's not a major player. These others really are the oxidant gases and toxic chemicals, and what we see from those chemicals is we see free radicals, and we see platelet activation, we see activation of cytokines. And with that, there are a number of things that happen. With the activation, with the inflammatory changes, one of the things that happens in the vessels is additional plaque buildup. So the level of plaque starts to build. And then there's also, with inflammatory changes, there's changes in the way that plaque is composed, and it creates some plaque instability. And we're going to get into that in a little bit. On the venous side, and that's on the arterial side, and that's going to be leading to heart attacks and strokes. On the venous side, what we have is activation of the clotting cascade. And those are the prothrombotic factors, and then also platelet activation. What that is doing is it is shifting the balance of clotting and thrombolysis toward clotting, so that we have a greater incidence of DVT, deep vein thrombosis, and pulmonary emboli. So those really are pretty major changes and large impact kind of changes that occur in the vessels. These other ones do occur, the cardiac changes do occur, the vessel changes do occur, but it's not clear kind of how much of an actual clinical impact they have. So let's jump into heart disease. Thanks for surviving the big messy slide here. Heart disease. So myocardial infarction, there's really two different impacts that smoking has that lead to heart attack. And we just talked about these. One is simple plaque burden. And with plaque burden, it's just the amount of plaque that builds up in the arteries. and there's actually a dose relationship between smoking and pack years. And when I say pack years, let me clarify, because I often will say there's a dose relationship between smoking. And what I'm always talking about there is pack years. And that is, if you smoke 1 pack of cigarettes per day for a year, that's 1 pack year. If you smoke a pack a day for 20 years, that's a 20 pack year history. If you smoke 2 packs a day for 20 years, that's a 40 pack years history. And that pack year history is very predictive of a lot of different types of illness. Lung disease, vascular disease, and cancer. It's all based on pack year history, and there's a very clear dose response with many of the pathological changes that we see from smoking. So plaque burden, dose relationship between pack years and plaque buildup. Plaque instability, however, does not appear to be related to pack year history, but more to active smoking, to ongoing smoking. And there's a funny finding, which was that people, and this is really looked at in terms of actual myocardial infarction. And maybe let's step back for a second, because myocardial infarction is not simply caused by plaque buildup. Myocardial infarction happens when a plaque builds up to a reasonable size, but then is also unstable and ruptures. And when it ruptures, the elements of the blood that cause clotting interpret that as actually, it's the same way as they interpret a break in the skin, and they say, uh-oh, there's a break here, we need to stop the bleeding, and it forms a clot. And so it's not simply plaque buildup, it's plaque rupture followed by a clot that develops in the artery, and that's a heart attack, and that's also a stroke. And so it's plaque burden, yes, but it's also the instability of that plaque. And there was a funny study that was done. I put a link to it in here at the bottom that showed, and this is the same thing. This is the Hackshaw study. And what it showed is that people can decrease the amount that they smoke. They can go from 2 packs to 1 pack to 10 cigarettes to 5 cigarettes without much of a change in the incidence of myocardial infarction. But once they get down to 0 cigarettes, then they see a real drop in the incidence of myocardial infarction. And the way that this has been interpreted is in terms of plaque instability. That plaque, when there's a lot of inflammatory cytokines running around the bloodstream, which apparently can be kicked up even from a small amount of smoking, that leads to a degree of plaque instability and a higher risk of myocardial infarction. And there seems to be a bit of a stair-step function, not a gradual function that we have with most things, but either we have the inflammatory changes or we're smoking 0 and we don't. So with most pathologic changes in smoking, we look at harm reduction, we look at gradual. This little case of myocardial infarction is different, where we really need complete smoking cessation to reduce the incidence of myocardial infarction. So kind of interesting stuff there. Ischemic stroke, again, clot forms in an artery in the brain, it ruptures. We see a causal relationship between smoking, and again, this is pack years, and the risk of ischemic stroke. And here's the thing about pack years. There was an interesting study in 2019 looking at kind of whether an increase in the amount that people smoke per day is actually related to stroke. And there's actually a very strong increase for every 5 cigarettes. For every increase of 5 cigarettes per day, we have an increase of about 12% risk of stroke. So we're going, from 5 to 10, from 10 to 15, we're increasing 12, and then another 12, and then another 12. So very, again, a dose relationship between smoking and stroke. AAA, abdominal aortic aneurysm. In the U.S., so there's a causal relationship between smoking and AAA. This has to do with endothelial dysfunction. And again, you think about inflammatory cytokines and that the vessel walls are responding to these inflammatory cytokines. And one of the things that happens is plaque buildup, but another thing that happens is aneurysm. And here we see that with AAA. And the U.S. Preventative Task Force has made a recommendation that men age 65 to 75 who have smoked get a single ultrasound. It's interesting that the data did not pan out as significant for women here, but sometimes that's simply because we need larger studies to demonstrate significance. So my guess is that this will eventually expand to women, but the initial study just showed significance in men. Venous thrombosis. So now we're on the venous side, and we have an increase in clotting factors, again caused by these inflammatory cytokines from smoking, von Willebrand's factor, thrombin, fibrinogen, and that impairs the breakdown of clot. And the way that I think about this is little tiny clots are always forming through the body. There's a little interpretation. Oh, maybe there's a break here. Maybe we need to make a clot. It looks like we don't, and then we break that down, and that's happening all the time in the bloodstream. And what this is doing, what smoking is doing, and the inflammatory mediators is shifting the balance toward clotting. And that leads to a causal relationship between active, ongoing smoking and DVT and pulmonary emboli. Now here, we're not talking about pack years. Here we're talking about either active smoking or not active smoking. You stop smoking, a month later, this has all gone away. A week later, this has all gone away. Those inflammatory levels come down, and we don't have to worry about smoking. Now let's think about surgical risk, and we're going to talk a little bit about surgical patients and medical management of those patients in a couple of videos from now. But let's just look at the health impacts. And I think there's an easy way to remember this. So first of all, there are multiple pathological entities that need to be assessed and that have been assessed comparing smokers and non-smokers. And some of the big ones are septic shock, sepsis itself, transfusions, MI, cardiac arrest, coma, being put on a ventilator after surgery, pulmonary embolism after surgery, intubation after surgery, which is unplanned, pneumonia, and then mortality and all major morbidity. The way that I think about this, and there's an increase in almost all of these, but the way that I think about this is that there's approximately a 50% increase in any post-operative complication when comparing a smoker to a non-smoker. And I'll say this again because it's something that's easy enough that we can remember it. There's approximately a 50% increase in any post-operative complication when comparing a smoker to a non-smoker. And that's fairly simple. And then the next question, of course, that comes up is what if people quit smoking? Does that go away or not? And the short answer is about 50% of that deficit goes away. So what we see, here's a meta-analysis of 9 trials and looking at quitting, and the mean time that we're looking at is about 3 weeks of quitting here. So people who quit 3 weeks prior to surgery, and it showed an average of a 22% drop in all postoperative complications. That includes pulmonary complications, wound healing, and this also showed that longer periods of abstinence were associated with greater complications, meaning greater reduction in complications, meaning that if you can get somebody to quit a month before surgery or 6 weeks before surgery, the longer that they're quit, the more those postoperative complications decrease. And I don't know about, countries around the world and medical systems, but there's an enormous amount of money spent managing postoperative complications. And this is an area where hospital administrators and governments and insurance companies, they're very interested in getting postoperative complications down because they're so expensive. And that sounds a little cold, but that is the mind of administrators, and how to get programs started is to be able to talk about the finances related to this. So I'll say it again, just to kind of go back. We have about a 50% increase in any of these. That's a mean, but 50% increase comparing a smoker to a non-smoker and these postoperative complications. And from that, we have about a 22% drop. If people quit several weeks before surgery, then we see about half of that increase go away. So pretty dramatic change just for quitting several weeks before surgery. And we're going to talk about the timing of quitting a little bit later on. We'll dive into that more because I think that that's interesting. Smoking as a cause of diabetes. So we've moved out of the vessels now, and the toxins are now crossing from the vessels into tissues and into cellular space. What happens when toxins and inflammatory factors from smoke get into the cells of the body? Well, one of the things that happens is that cells become more resistant to glucose, so that glucose that's coming through the blood has a more difficult time getting into those cells, and that's insulin resistance. That's type 2 diabetes. That's the underlying mechanism of type 2 diabetes. And because of that increased, and the hemoglobin A1C will go up about 1.5 points, is about how much you get in a smoker compared to a non-smoker. And when smokers quit, it'll come down, hemoglobin A1Cs will come down about 1.5 points. But when looking at smokers versus non-smokers, smokers are about 35% more likely to develop diabetes. And this is actually related to the amount that people are smoking. We have about a 25% increased risk for light smokers, and that's people who smoke 1 to 15 cigarettes a day, and about a 50% increase for heavier smokers, people who are smoking over 15 cigarettes a day. That was a study by Tonstad, who we've worked with some. Overall, about 12% of diabetes is now considered to be actually caused by smoking. Really what that means is that the hemoglobin A1C is increasing in a portion of patients and crosses the threshold where we actually call it diabetes. And so that's really what that is. The way that I think about this is just insulin resistance. Smoking leads to inflammatory changes in the cells, which increases insulin resistance. The more you smoke, the worse it is. So I think this goes without saying, but smoking increases the risk of diabetic complications. Diabetics already have a higher incidence of heart disease, renal disease, peripheral vascular disease, multiple kinds of infections, retinopathy, peripheral neuropathy. All of these things get worse in smokers because of separate pathways where smoking is also impacting heart disease and renal disease and vascular disease and infections. So kind of a double whammy. Something that I think we really have worked with at Duke, and I'm really starting to see is that individual providers, cardiologists, endocrine folks, are really interested in bringing on tobacco treatment as to assist with their patients and the problems that they're running into because of tobacco use. For instance, pairing up with cardiology, it just makes sense because so many people who are smoking and have heart problems need to quit, and we need specialized treatment. We need insightful treatment, the kind of things that we're going to be talking about here soon. This is actually true for diabetes as well, and there's been a real need to connect diabetes services and smoking cessation services to manage those patients because of the increased risk of diabetes and diabetic complications in people who smoke. Developmental effects. So one of the things that I think is important, and we talked about this with the nicotine molecule being so small, is that nicotine comes into the body. It can easily cross the placenta and enter in to the development of the child. And this is something that, in fact, this is the nicotine that's causing these problems. We get about a 27% increase in preterm delivery comparing smokers to non-smokers, associated with 13 and 19% low birth weight low birth weight deliveries, and then also ectopic pregnancy. So a lot of different A lot of different changes. We also see nicotine by itself leading to later stage ADHD. This is in teenagers, and here looks like it's just nicotine and not smoking. So very kind of profound effects, and I think it's very important for women to try to quit smoking while they're pregnant. One of the recent findings, and this really came out in the last few years, is that with the development, is smokers with HIV, for smokers who have HIV in the United States, they now have a greater chance of dying from smoking-related illnesses than from HIV-related illnesses. This is because of several factors, and we're going to get into those in just a second. But mortality rates are about 2 times as high for smokers who have HIV versus non-smokers who have HIV. So smoking has a huge impact on this population. Why is that? The first thing is that smoking rates are very high in the HIV population, HIV positive population. We have about 45% in the U.S. Of HIV positive people smoking versus about 15% in the rest of the U.S. I actually don't know that data in other countries, and I'd be interested if folks in this course do know that information. I think it's, I looked for it and couldn't find it. But it's very, we definitely see much higher rates of smoking. The other is that cancer risks are much higher for people who have HIV who smoke versus people who have HIV and don't smoke. And this includes lung cancer, head and neck, cervical cancers. Infection rates are also more likely in HIV folks who smoke versus who don't smoke. And that includes pneumonia, PCP, and then also we have the same risks of COPD and heart disease, and they have poor response to antiretroviral treatments, and that again may have to do with inflammatory changes, but altogether, and with the fact that antiretroviral treatments are working well, the risk of dying in people who have HIV is now greater from illnesses related to smoking. Let's talk a little bit about cancers. So the way that I talk to patients about this, I'll say it again, smoke comes into the body, moves into the vessels, goes through the body, toxins in the vessels go through the entire body, and essentially every organ in the body is bathed in blood and is impacted by those toxins. And what that means is that smoking doesn't just cause lung cancer, and I think that that's important for patients to know, that smoking leads to many different kinds of cancers. There are 13 cancers which have been identified as being caused by smoking in the last Surgeon General's report, and I want to kind of go over some of those. Bladder cancer is important. Almost just about everyone with bladder cancer, the great majority of people with bladder cancer, are smokers. Now, the reason for that is that the toxins that come into the bloodstream are eventually filtered out by the kidneys and to remove them from the blood, and then they go into the bladder. What that means is that the bladder wall is exposed to urine day in and day out that has a high level of these carcinogens. These are very concentrated carcinogens compared to what they are in the bloodstream, because they're all filtered out and then they are essentially kept there in the bladder at a high concentration. So the bladder wall is exposed to very high levels of toxins, and the relative risk, looking at smokers versus non-smokers, of getting bladder cancer is about 2.7 to 2.8. When a person quits smoking, that relative risk comes down, and this is looking at former smokers versus non-smokers, so it comes down from about 2.7 to 1.7. So, and this is looking 2 years after quitting. So we see a reduction in all of these, and for most of these, we see that within the first 2 years that the risk of cancer is about cut in half. That's kind of a ballparky zone. Breast cancer, about a 30% increase in breast cancer for those who smoke and don't versus don't smoke. Cervical cancer, there's almost a double the risk of getting cervical cancer for people who smoke. We know about lung cancer. Colon cancer, 70% increased risk. Esophageal cancer is much higher. Renal cancer, 50%. Leukemia, gastric, pancreatic. And then for each of these, when you quit smoking, you're just about cutting those risks in half within the first couple of years. So lots of different cancers that are associated with smoking, and very consistent pattern of decreasing that risk after quitting. Let's look at lung cancer just a little bit, because that's the big killer for smoking. So this is the second most common cancer in humans, and that's if we exclude skin cancer, which is the most common, but often is so small that we're not worried about it. It's for these squamous cells and all. But the most common cancer is of course prostate for men and breast cancer for women, and then the second for both is lung cancer. Smokers are 25 times more likely to develop lung cancer than non-smokers. And here is the kicker with lung cancer, is that survival is so poor. Survival is about 20% for all lung cancers, and about 6% for small cell lung cancers. Why is that? The reason is that lung cancers develop and they get larger and larger, and then eventually spread. And of course, the lungs are highly vascular, and eventually spread around the body. And by the time the symptoms develop, they've already spread. And so the reason that this is such a low 5-year survival is because most cancers are typically caught at stage 4, some at stage 3, but the only way to catch these very early cancers at stage 1 is with screening. And there's a real push to do lung cancer screening now in the U.S., and I hope that extends, that recognition starts to kind of move across other countries as well. But the risk of lung cancer, again, is associated with pack year history, how much you have smoked, and then that comes down with quitting. And let's look at this next slide, because this really looks at quitting. So what happens when you quit, and quit by a certain age? And what this chart shows, this chart was done in 2000, and what it shows is the lifelong risk of getting lung cancer if you smoke for some period of time and then quit by a particular age. And for people who have never smoked, the lifelong risk of lung cancer is under 1%. If people stop by age 30, it's 2%. So, but if they stop by age 50, we're looking at 6%, and if they smoke through their entire lives, the risk of getting lung cancer is about 16%. So nice argument for trying to get people to quit smoking as early as possible. As they smoke through their lives, that risk just increases year by year. So what about treating people who have already developed cancer? And this is something, so one of the things that we do at Duke is we run a specialized smoking cessation program out of the cancer center. And it specifically treats people. It's there to treat people who already have cancer. And there is a kind of sentiment among some of those patients to say, well, I've already gotten cancer. Now what's the use? Why should I, at least I should, smoke and enjoy myself rather than trying to quit. The data on this is actually very compelling, and I want to go over a little bit of it. One is that the risk of cancer recurrence. So a lot of these people are actually going to get over their cancer, and the risk of that cancer coming back is much higher if people continue smoking. It's about a 40% increase in cancer recurrence compared to non-smokers. If they quit smoking, that drops down to about 10% over a never smoker. So big difference in cancer recurrence. And the other is a risk of a second primary cancer, and that's about twice as high in non-smokers, and then drops down really significantly if people quit. So big impacts of quitting after people have gotten cancer, if you're looking at cancer recurrence or the occurrence of a second of another cancer. The other thing is that treatment is much more effective. So there is, and here we're going to look at side effects. There's significant increase for smokers in chemotherapy-related side effects, weight loss, cachexia, fatigue, and a decrease in severe side effects for if people quit smoking. So we see smokers with about 50% of them getting severe side effects. If people quit smoking, that drops to about 31%. So these are dreaded side effects, and for people getting cancer. And if they quit smoking, then many people can avoid some of these side effects. Radiotherapy is also more effective in people who quit smoking, and complications are less. And then the last thing I want to go over is secondhand smoke. And I should just say, within the realm of the pathology of smoking, there's a lot of things we didn't talk about. We didn't talk about rheumatologic disease. Smoking is related now to rheumatoid arthritis, bone loss. Smoking increases bone demineralization and is now associated with bone fractures. And osteoporosis, as well as osteopenia. Erectile dysfunction is another one. Macular degeneration is another one. Cataracts is another one. There's a whole litany of oral problems with tooth decay and tooth loss, which are related. And I wanted to just limit the amount of information that you had in this one video, and just kind of be as kind as possible to everyone watching, because it can get lengthy. But the number of pathological problems are just immense, and really impressive. And I think for the most part, our patients don't know about them. I think for the most part, our patients know about lung cancer, and they know about COPD or emphysema. But the others, by and large, they don't actually know about. So what about secondhand smoke? Secondhand smoke is not as deadly. The impacts are not as deadly because people are not getting as much smoke as they do when they're smoking themselves. That said, the type of smoke that they're getting actually has more carcinogens. This side stream smoke. So there's two kinds of smoke that you get from smoking. One is smoke that smokers pull through the filter, and they inhale the smoke through the filter, and the filter decreases the level of carcinogens in the smoke. The other is smoke that's coming off the end of the cigarette. And the majority of smoke, when a person is smoking in a room, the majority of smoke that's in the room is from that side stream smoke. It's the smoke off the end of the cigarette that's unfiltered. It's not actually the smoke that the person is blowing out when they exhale smoke after smoking themselves. So it's about 85% of secondhand smoke is actually, they call it side stream, which is off the end, not mainstream, which is through the cigarette. So it is. Mainstream smoke side stream smoke is a little more carcinogenic. In the U.S., we see about 42,000 deaths just from heart disease from non-smokers, and the calculation here is a covariate analysis looking at heart disease that would have caused a death versus wouldn't have caused a death, and comparing people who have exposure to secondhand smoke to those who don't have secondhand smoke with propensity matching on other variables. And then we also see just a lot of respiratory tract infection in infants and children who live in households of people who smoke. The other thing I want to mention is third-hand smoke, and this is a term that I think is worth learning. Actually, let me go back to secondhand smoke just for one kind of other piece, and that is that the reason that secondhand smoke and really understanding secondhand smoke has become so important is really legislation and regulations. It's very difficult to regulate what people do in their own homes, and it's very difficult to tell people you can't do something because it harms you. However, it absolutely makes sense to restrict people's behavior when it's hurting others. And this is where secondhand smoke has become so important. And if we want to make policy around smoking in public places, or make legislation about smoking that create policy around entire country, or regulations about smaller areas, that's an issue of secondhand smoke. That's the language of that legislation, is the language of secondhand smoke. Third-hand smoke is kind of an interesting term that I think is worth knowing, and that refers to residue that forms on furniture, walls, curtains, beds, whatever, in a home where people are smoking. And that is that the particulate matter from smoking, when it's in the air, eventually drifts down and lands on things. And you can see in the home of a person who's smoking, if they have white walls especially, you can see that there's a slight kind of brown patina, kind of yellowy brown patina that develops on those walls. That's third-hand smoke. That is smoke that's stuff from the air that is deposited on the walls, and that deposits on everything. You just can't see it as well as on the walls. And those carcinogens actually oxidize and break down over time, and they become more carcinogenic over time with that breakdown. So this stuff is pretty toxic, the third-hand smoke, this deposition. And for the most part, adults you don't have to worry about it, but children really do. So children interact with surfaces around the house all the time, and they're always sticking their hands in their mouth. I'd love to say my kids haven't done it, but they absolutely did. And so that's the real risk there. And I would say to patients, if they can't quit smoking and they have young children, just to ask people to smoke outside the house so that you don't get that secondhand smoke exposure in the house with these respiratory tract infections, and you don't get that third-hand smoke, which is really very toxic. That's it for our pathology section, and I look forward to the next section, as I'm very excited about it, which is the neurobiology of smoking, and I think that you'll find that to be very interesting. We'll make it as simple and engaging as possible. Thanks so much.